Well, hello, everybody. Good evening. This is Dr. Baron Lahner here with you from Mount Sinai Hospital in New York. I'm here with our expert panel and patient champions to present a webinar, the Power Over Scoliosis webinar this evening. I'm co-moderating with Stephen George. Next slide, please. And here's Stephen from University of Miami Children's Hospital. Next slide. So we have a terrific panel this evening. Dr. George will be speaking, Dr. Wise from Scottish Rite Children's Center, Dr. Cahill from Children's Hospital Philadelphia, and of course, Michelle Marks, our Executive Director of the Setting Scoliosis Straight Foundation. So we have a terrific group this evening, and our guest patient speakers, I call them champions. Sage Spear will be telling us her story about bracing, and Jules Guarrera about her surgical story of spinal fusion. Next slide. So for all attendees, those of you in the audience, please submit questions. We really like to have an active Q&A session, questions and answers, and you can use the Q&A mode down below at the bottom of your Zoom screen and just type in your questions there, and we'll do our best to answer them either verbally or in written response. Next slide, please. So this is the list of talks that we're going to be presenting this evening. I won't spend time on this, but I think you'll find this to be a very informative webinar and excellent speakers who are with us this evening. Next slide. And I just wanted to let you know that we're representing the Setting Scoliosis Straight Foundation. We're a nonprofit organization that was established in 2018, but we've been at this for nearly 3 decades in providing research, with our mission being to better discoveries and advanced techniques in the treatment of scoliosis in children and adolescents worldwide. And our vision is a future where children with scoliosis have the ability to live healthy, happy, and productive lives. Next slide, please. So without further ado, Dr. George will be giving us an introduction on scoliosis and speaking about radiation exposure as well. So Dr. George.
Hey, thank you so much, Dr. Lahner. Appreciate it. Thank you guys for joining us this evening. Certainly a pleasure to be here and to talk with you guys. Today, I'll be giving a short talk on Scoliosis 101 and a little bit about radiation considerations as we think about scoliosis and the treatment and so on. What is scoliosis? Well, by definition, when we say scoliosis, we're talking about a lateral curvature in the spine greater than 10 degrees. We say greater than 10 degrees because under 10 degrees, we really consider within normal limits. Now, as we think about scoliosis and the types of scoliosis that we see and treat, one of which is idiopathic scoliosis. And we'll be talking a lot about idiopathic scoliosis. And in this condition, one of the abnormalities in this condition is the actual building block of the spine, the vertebra, is actually misshapen. So you see here on the bottom left, a normal vertebra having almost parallel top and bottom, whereas it's a little bit different here. It's wedged a little bit with the idiopathic population. I mentioned different types of scoliosis, and this is true. I mean, the most common that we see is one called idiopathic scoliosis. It's more common in females than males. We know that there's a genetic component, but we're still uncertain of exactly where, on which chromosome and so on, the scoliosis gene is found, and its inheritance pattern. The other type of scoliosis that we deal with is one called neuromuscular scoliosis. This is one in which we find in patients with cerebral palsy and other conditions like that, where we have an imbalance in the muscles, and that imbalance causes a curvature of the spine as well. The other type of scoliosis that we commonly deal with is congenital scoliosis. This is a type of scoliosis where the vertebral body develops improperly, whether it's part of the body doesn't form, or sometimes it doesn't separate as it's supposed to during development. We're going to talk a little bit more about adolescent idiopathic scoliosis, commonly called AIS. In this condition, not only is this a spine condition where we see a curvature of the spine, but we also see deformity in the chest and rib as well. We see that in some studies that look at CAT scans of patients with this deformity, you see on the bottom right here, the chest from left to right look very, very different. And it takes on a shape almost like we see on the left-hand side here, where one side has a prominent hump and the other side is more blunted on the concave side. And this again is some of the things we look out for when AIS. A little review on AIS, we see that we find it in about 3% of the population, okay? But in that, of that, I mean, only a small portion actually are considered to have moderate to severe type curves. Again, it's highly weighted in females versus males, almost 10 to 1, some studies show. Usually develops in the prepubescent years. And again, one of the things that fuels these deformities to progress is growth. So during, the prepubescent period is when individuals are growing the fastest. So that's why we see them develop and progress most during that time. As I said before, we know that, many of these patients have a family history, but it's still very unclear as to exactly how it's inherited. One thing that we see is that even though you have this deformity, usually it does not cause back pain. A lot of people say, well, I don't have any pain. I must not have scoliosis. This is not necessarily the case. These do not cause back pain for the most part. It's not caused by heavy book bags or bad posture. This is something genetically related that isn't impacted by these things. The natural history of the deformity really depends on a few different things. One major thing is the size of the curve, but the other major thing is the stage of skeletal maturity, meaning are your bones mature or are they immature and have a lot of growth potential remaining? What we see is that patients who have more growth remaining or larger curves have a higher likelihood for the curves to actually progress or get worse. Now, the primary treatment for this condition is sort of broken up into 3 categories: observe, brace, and potential surgical intervention. When we think about the severity of these curves, we kind of break it down into mild, moderate, and severe or progressive. Mild curves range from about 10 to 25 degrees. As I said before, curves under that are considered within normal limits. Moderate curves being between 25 and 45, and more severe and progressive curves between 45 and 50 degrees. And again, these aren't arbitrarily divided. What we see is that the severe and more progressive curves happen at about that range. So there are several long-term studies that really looked at what happens in the natural history of scoliosis, and what they see is that when curves get to be about this size, if nothing is done, they continue to progress during skeletal maturity and after skeletal maturity. So how do we see this clinically? Well, some common findings would include an uneven shoulder, as you can see on the right-hand side here. You can see uneven shoulder blades. You can even see some waist or hip asymmetry. You can actually see the chest or trunk shift. And sometimes you can just see the curvature of the spine. But one very common thing we see is this rib hump on forward bend. And this is what's used as a screening tool in most doctor's offices and schools. How this basically basically works is when the individual bends forward, that rib hump actually accentuates, gets worse. And according to how big that rib hump is, that unevenness actually usually represents the curvature of the spine. And again, these are not just side-to-side curves; these are three-dimensional curves, and this is one way that that it's demonstrated. So for evaluation, usually the X-ray is used, an AP or a front-to-back X-ray you see on the left, and a side view. And in scoliosis, again, we see the curvature on the AP view, but on the lateral view, on the right-hand side, we see oftentimes a flattening of the spine in the thoracic region, and then we see these flaring of the ribs in the back here, which represent that rib hump that's accentuated as you bend forward. Now, this is something that we should also keep in mind. The primary way that we really diagnose scoliosis is with an X-ray, and when you follow patients with scoliosis, it usually requires repeated X-rays to document any progression. What we really are now keenly aware of is that this radiation exposure through these X-rays aren't benign. A patient who is treated non-operatively for adolescent idiopathic scoliosis usually has about 9 to 10 full spine X-rays during that period of non-operative treatment. And patients who require surgery usually get about 15 to 16 X-rays in total over the course of their treatment. This is important, and no radiation is good in this situation, and it's hard to know how much radiation is too much. But what studies have now are starting to find is that females with idiopathic scoliosis may have up to a 1.2 times increase odds of developing breast cancer in a lifetime compared to females without this deformity. Now, there's a lot baked into that, but I think what the takeaway here is that we really need to reduce the amount of radiation that we put our patients through. And one of the big things that have pushed us in the right direction is low radiation X-ray with this EOS machine that we now utilize. This machine allows us to take full standing radiographs with 90% less radiation. It really has revolutionized how we diagnose and treat the condition for several reasons. It also allows us to get a 3D rendering of the spine, as you can see. So here's the machine, and here's just the standard X-ray. But it actually, again, with an algorithm it uses, allows us to get this 3D image of the spine, which gives us a great idea of the complexity of the deformity and, better ways on how to treat it. Now, treatment, as I said, is very dependent on the severity of the curve. Mild curves, again, usually are treated with observation. We try to monitor the curve progression. We also may initiate things like Schroth therapy in this situation as well. And as I said, risk factors for progression would include immaturity, bigger curves, and certain curve patterns we see that have a higher propensity to progress. Now, in the moderate size curves, again, some of the foundations for treatment here are bracing, and we'd also add Schroth therapy to that and other therapy modalities. And we'll have a patient who's on that will give you her story through bracing. And now, in the more severe and progressive curves, this is where surgical intervention comes into consideration. Our most common procedure for this condition is the posterior spinal fusion, and also now the vertebral body tethering, which is also done. Down here, we have X-rays of a patient with scoliosis, and this is a posterior spinal fusion. Again, this includes rods and screws that are used to basically fuse the area that's most deformed, and here's in the front plane and the side plane. And, to be honest, this is something that patients do very well after undergoing. Usually they're in the hospital for a couple of days. They walk on the first day. They return to school in 2 to 3 weeks. Most activities in 3 months, and all activities with no limitations in about 6 months. So I hope this was helpful, just a quick overview of scoliosis and some radiation considerations. I want to thank all you guys for joining, and thank my patients who just continue to make me better. Here they are, just living their best life, and I'm just so proud of them. So thank you.
Thank you, Steve. Everything you wanted to know about scoliosis in 7 minutes. So we went
Yeah.
over a little here. But Stephen and all, we have some Q&A. We can answer those questions, typing the answers for those who reached out. So I think we can all do that. We're going to go on now to Dr. Wise, who is a genius in the area of genetics. And Dr. George brought some of this up in his talk. So Dr. Wise, without further ado, we look forward to hearing from you.
Okay. Sorry, I had to go backwards through my slides, and that has to be perhaps the most exaggerated and lovely introduction I've had.
It wasn't exaggerated, but could you also put yourself in slide view?
Yes.
Thank you.
Yes.
All right,
So
I'm going to be quiet now and listen.
thank you so much. It's my great pleasure to be here and to be asked to speak to this group. So yes, I'm going to speak to you very briefly about what we know about the genetics of scoliosis. And let's see, my advance is not working. Okay. Here we go.
There you go.
Yeah, okay. So you've heard a great introduction by my predecessor about scoliosis. This audience knows scoliosis very well. It's the poster child for orthopedics, and it is a spinal curvature that can develop at different times in life. And so in genetics, you heard about scoliosis being divided, described by different sort of clinical presentations. And in genetics, oftentimes we describe it by the age at onset. And so there's a form of scoliosis called early, and congenital that you heard about earlier is an early onset form of scoliosis. So the early onset group is really many different diagnoses, as you see here by all these wonderful pictures that were provided to me by my colleague, Dr. Ramo. And then there's another form of scoliosis that you may have heard about that people call adult scoliosis. And this tends to be secondary to some of the things that happen during aging. For example, disc degeneration and osteoporosis. And then, of course, the most common form, which you've heard about previously, is the adolescent onset form that happens in otherwise apparently healthy children during the adolescent growth spurt. And so what do we know about these from the viewpoint of genetics? And when we talk about genetics, we're talking about the area of biology that's the study of inheritance. And how are these disorders inherited? How do the genes interplay? What is the DNA variation and the interactions, and how do they interact with environmental factors to cause disease? So that's sort of the global definition of genetics. And that's what some of us spend a lot of our time working on. And so in my world, in genetics, we think about genetic disorders in sort of two big buckets. And one is what we call single gene disorders. And this is kind of what we tend to think of when we talk about a genetic disease. And that's where, as you see on the left, this is a pedigree or family tree, and the squares are males and the circles are females, and black symbols represent someone who has a particular disease. And you can appreciate very quickly looking at this family tree that this disease is inherited in every single generation. It's what we call a dominant disorder. And so we know in that situation, this is likely caused by a single gene. One misspelling in the genome causes this disorder to arise in a family. And these days, with modern technologies, those are pretty easy to test and identify in patients. And then there might be another type of single gene disorder that's actually misspellings inherited from both parents and arising in a child, but it's still considered a single gene disorder that's causing that. Many of the early onset forms of scoliosis are single gene disorders. And again, remember I told you that early onset is sort of a heterogeneous mix of many different diagnoses. And many of these are genetic. And so what we're finding more and more is that sometimes these patients that present with scoliosis early in life have an unrecognized genetic disorder, and we encourage our colleagues to send them over for clinical genetic testing. And I'm not going to talk about adult scoliosis. That's really more of an environmental and aging thing. But now let's talk about adolescent idiopathic scoliosis, or AIS. This is the big one, and this is the one that probably most of us in the room are thinking about. Again, the most common form of scoliosis. And number one thing take home here is that adolescent idiopathic scoliosis is what we call a complex genetic disease. It is not a single gene disorder. It is not a single misspelling like you saw in my previous slides. This is a situation where many genetic changes in each individual patient come together and increase the risk of developing AIS. And that's why we show it, as you see on the left, it's as if you have many, many puzzle pieces that come together and increase the risk of this disorder. And so over the years, we have identified many of those puzzle pieces, and I'm just showing you clips of some of the papers that have been published. And so what has this taught us? What it's taught us is that, yes, indeed, it is a very complex disease. There are more genes to be discovered. But in studying what these genes do, we have learned in the past few years that the cartilage in spine is a relevant disease tissue. Many of these puzzle pieces, actually, these genes function in the cartilage of the spine, in the intervertebral disc, and in the growth plates near the IVD. And so now research is very focused on how those players are coming together to cause AIS. And there's more research to be done to find more of those puzzle pieces. So what about genetic testing for AIS? That's something that's very important to us, and obviously it's very important to patients. Is there a test to tell a patient if they're going to develop AIS? And the answer is not yet, but it is coming. So I'm showing you here a picture of my friend and colleague, Dr. Nao Otomo. He's a researcher in Tokyo, Japan right now. Currently, he's doing a fellowship in my lab. And he has published a paper showing that if you test for many of those puzzle pieces, if you will, a selected panel of genes, it's called a polygenic risk score, you can sort of divide patient groups into high risk versus low group. So in his test, by using these selected genetic variants, the test showed over 60% sensitivity and specificity for distinguishing the high-risk groups from the low-risk groups. And if they put other information into their algorithm, for example, body mass index, that improved the sensitivity and specificity of the test. So what is all that? And what about testing for AIS progression? In his study, he also showed that these factors could distinguish high Cobb angle patients from the lowest Cobb angle patients. So what does all that mean? The test is not good enough yet for clinical use. We want it to be much higher sensitivity and specificity, but it is a very good start. And so with more research, we are very focused on improving that test, number one, and number two, developing a test that would be useful for many populations around the world. So to summarize, we've come a long way in understanding AIS, and I show the slide on the right because obviously this is a very old picture. AIS has been around for a long time, and with modern technologies in the last 10 plus years, we're really starting to get a handle on what is causal and factors that could help us with better diagnosis and treatment in the clinics. So as I was saying, research is continuing to understand not only genetics, but in this case, genetics, it's an interplay between genetics, between sex. You heard earlier that females are at much greater risk for progressive disease than males. And so there are hormonal influences and obviously the mechanical stresses of growth. So again, with a major goal of leading to better testing and prevention of this disorder. So I thank you very much. I thank you so much for your attention. I always thank the patients and families who are the absolute drivers of the work that we do, and all of my wonderful collaborators. And I'm happy to answer questions if there are any, if there is time available.
Thank you, Dr. Wise, for just a fantastic talk. I mean, certainly you're on the cutting edge of helping us figure this all out. For those who have questions, I'd ask to put them in the chat here, and we'll definitely get to those. We're going to try to move on here to make up a little bit of time here. I'd like to introduce Dr. Cahill, who's going to give us a talk on pregnancy after spinal fusion.
Great, thanks, Stephen. I will share my screen and thanks. So I'm going to talk about kind of what comes after surgery. If you're one of those families and patients that have had to have scoliosis surgery, what does that mean? And if I was giving this talk 30 years ago, I would say that would be a definitive branch point in your life. Your life would probably not be the same afterwards. You would probably not be able to do gym class or sports after that. And a lot of those patients had to grow up and look for sedentary or desk type jobs. But nowadays, I like to describe it as more of something that it's a bump in the road. It may ruin your summer or your spring or whenever you have your surgery, but it's not something that will necessarily change the trajectory of your life and the activities you do and what you want to be and do when you grow up. So that's not to say there might not be some bumps in the road. So these are some papers, including from Dr. Wise's institution, that shows that even when you do have a fusion surgery, there's still a chance of needing other surgeries on your back at some point in your life. And that's why it's important to continue to keep checking in with your doctor for a few years, maybe even up to 5 years after your surgery, just to make sure that there's no signs of problems with the bones healing or the rods breaking and things like that. Because maybe even up to 13 to 18% of patients may need another surgery for one of those reasons. And here's some data from this group, the harm study group, that shows that even up to 10 years, 90% of patients have not had to have another surgery. And the good news is, even if you do have to have another surgery, we've shown that once that problem is addressed, you can expect the same normal, pain-free life as somebody who has not had another surgery or a problem that's led to another surgery. So the vast majority of patients are pain-free indefinitely after their surgeries once they recover from the initial time after surgery. It should not limit your career choice and almost any sport that you want to play, with some doctors sometimes limiting a few sports like wrestling and rugby and tackle football. But for the most part, almost every sport is okay to go back to once you've had a full recovery from your surgery. And the real big question I wanted to talk to everybody about is what's going to happen for those female patients long-term if and when the time comes to think about having their own babies. And there's a lot of really important questions. Is there going to be enough room for my baby? Will the rods and lack of motion or limitation in motion limit room for the baby or somehow affect the delivery process? And what I can tell you is that it probably should not, but unfortunately, it still is affecting the way that women are treated in this country, in the United States. So this early study in the 1990s showed that there were some minor problems during pregnancy and delivery, maybe a higher rate of vacuum extraction, and maybe the severity and frequency of back pain in women that have had scoliosis, and in particular fusion surgery for scoliosis, maybe is higher, but it's hard to tell because that's a common finding in pregnancy as well. And so this group has tried to answer some of these questions. We sent questionnaires to all of our subjects that we've been studying long-term after a spine surgery for scoliosis. And we not only want to track them as long as we can, decades after their surgery, but we want to find out how pregnancies were for them, how the delivery process was. And so we sent them a number of questions, including some standardized questionnaires. And here's what we found is that more than half of our former subjects did not meet with their anesthesiologist during the pregnancy to talk about the plan for anesthesia during the labor and delivery. And here's just a diagram of some of the things that may be considered for women that are in childbirth. And this is an injection into the spinal fluid or an injection right next to the sac that has the spinal fluid, which is called an epidural injection, both of which can provide really good pain control and still allow for a safe labor and delivery. Unfortunately, what we found is that the women that have had a spinal fusion in their teenage years because of scoliosis seem to be getting a spinal or an epidural at a rate much lower than everybody else in this country. And we think that's not because they had scoliosis, it's because we haven't done a good job at teaching the obstetricians that it's okay for them to have spinals and epidurals. Because this is a different set of rods and implants than somebody who has them because of a fracture or because of arthritis or degenerative conditions in their lower back, which is closer to where the doctors like to put those spinals and epidurals. Almost everybody that has had scoliosis surgery should have room below where that set of implants and that fusion is for an anesthesiologist to put a spinal and epidural. And so we are working we've presented to the American College of Obstetrics and Gynecologists to try to educate them that this is an option that should be available to women that have had a scoliosis fusion, but it's also we're educating our patients to be their own advocates. And then one quick point, we asked, how is the baby doing for those women that have had a scoliosis fusion and a subsequent pregnancy? And all of the babies are doing great, except for one, which seems to be unrelated to the scoliosis surgery or anything going on in their spine. But here's what we try to educate our patients about once they leave our practice and go into adulthood. Keep a copy of your x-rays, put it somewhere with all of your COVID vaccinations and other medical information. And ideally, that's going to be printed out on a piece of paper or a film or a CD. And then you can show that to your obstetrician early in the pregnancy and say, hey, look, there's places here that you can put a spinal or an epidural if that's something you want during that pregnancy, and know exactly what your lowest level is so that you can have that conversation in an intelligent way with your obstetrician, or more importantly, ask to see the anesthesiologist early in the pregnancy so you can have a plan with them as well. And then ask your obstetrician if they've had experience dealing with women that have had a scoliosis fusion, and if they're comfortable with it, and if they're going to try to change the plan during labor and delivery because of your previous scoliosis surgery. And these are just some talking points, kind of just asking those same questions that I just talked about. And lastly, your scoliosis surgeon is also a resource. Your surgeon and their team should be a part of your life for the first 5 years or so after your surgery. But we love to get updates and find out how you're doing even beyond that. And if you're pregnant and having a hard time talking to your obstetrician about these sort of things, most AIS surgeons have relationships with obstetricians that know how to take care of women that have had these types of surgeries. And lastly, we of course love to find out how our patients are doing once they've gone off and grown up and doing great things. And we love baby pictures as well. Please use your surgeons as a resource throughout your life.
Thank you, Dr. Cahill. Pat, nice talk. I'm sure some of the participants may have questions, which we'd encourage you to place into the Q&A function here. So we're going to move on now to Michelle Marks' talk on motion after spinal fusion. Thanks, Michelle.
Thank you, Dr. Lahner. I'm going to share my screen. Let me know when you can see it, please.
We can see it.
Awesome, great. Okay, well, thank you for the opportunity to share this research with all the patients and families and healthcare providers that are on the call today and who might be viewing the recording later. I must thank the Harm Study Group and Setting Scoliosis Straight for providing me with an amazing career for the past 25 years. I personally don't have anything to disclose, but funding has been received to the Harm Study Group for this body of work, both from industry and society grant awards. And I really want to thank Maddie, Tracy, Rose, and Peter for all of their input on this work. So our efforts to evaluate spinal motion, they were initially inspired by an early publication evaluating scoliosis patients in a motion lab by Lanke and Ensberg. So we began our spinal motion assessment at the Rady Children's Hospital Motion Lab in San Diego. A motion analysis lab, it uses a 8-camera system that tracks reflective markers that are placed on a patient at 60 Hertz using an infrared strobe light. The marker coordinates are processed and motion is measured and quantified as seen here in this example of a golf swing analysis. And although advances in motion capture technology have greatly improved the accuracy of dynamic measurements, the limitation is the assumption that the skin markers move synchronously with underlying skeletal structures. So we conducted a pilot study to determine the validity of using motion capture technology to evaluate global and regional flexibility of the spine during functional bending movements, comparing a 2D versus a 3D marker set seen here in scoliosis patients. So pre-op radiographs for these scoliosis patients were acquired in the motion lab using a portable X-ray unit, and as the motion capture system was used simultaneously to record the positions of the reflective marker set. The results of our pilot study suggest that measurements of regional and global spinal flexibility using a motion lab may not accurately reflect X-ray measurements of motion. Therefore, we continued our research efforts evaluating the unfused distal spinal segment motion in scoliosis following fusions, and we used the radiographic summation of a static angle at each bend to equal the total motion at the respective vertebral segments. Our results showed the more distal or further down the spine, the lowest instrumented vertebra was, the more motion occurs at those remaining unfused segments. And in a subsequent study with 259 patients, our results showed that the unfused side bending coronal motion was not significantly different across early, midterm, or long-term follow-up. And in a subset of these patients with a primary thoracic curve and a C lumbar modifier, these are patients that could potentially have just their thoracic curve fused, our results showed that in patients that were fused longer, there is statistically more motion in the unfused segments versus with a selective fusion. This journey in motion assessment has brought us to our latest evaluation, and it's a comparison in scoliosis patients treated with tether, VBT, versus fusion, PSF, with the aims to quantify segmental and regional spinal motion and compare changes in patients at 2 to 3 years post-op. Vertebral body tethering is promoted as a motion preserving option compared to posterior spinal fusion, but through a simple Google search, patients are exposed to numerous claims regarding motion and function when faced with the surgical decision between the two. In this prospective study, 5 sites enrolled consecutive patients with major right thoracic scoliosis who underwent thoracic tether with the lowest instrument of vertebra between the vertebral segments T11 and L1, and who presented for follow-up at 2 to 3 years post-op, and then they consented for inclusion. The radiographs included coronal or side bending, pre and post upright, left and right max bend, and sagittal, which are forward bending, upright, pre and post, and a post-op max forward bend, all seen here. Radiographic angular measures were performed, as I described earlier, segmentally between 2 vertebrae, but also regionally, from the top to the bottom of the spine, representing overall spine motion, at the instrumented segment region, and from the lowest instrumented vertebra to the bottom of the spine, which represents the distal uninstrumented region. The summation of the static angle at each bend is representative of the dynamic relative movement. The tether patients were matched 1-to-1 with patients treated with fusion that were captured from our previous investigations. Matching criteria included curve pattern and lowest instrumented vertebra, and there were 32 patients in each cohort. Our results showed pre to post-op changes confirmed greater Cobb correction with a fusion and side bending motion loss in the instrumented segment. The tether is 50% of that of a fusion. Comparing tether to BBT to fusion PSF, the 2 patient cohorts at 2 to 3 years post-op. In the instrumented segment, VBT side bending and forward motion is about 11 to 12 degrees greater than posterior spinal fusion. In overall spinal motion, VBT forward bending is around 20 degrees more than posterior spinal fusion, but side bending motion isn't different. And in the distal unfused segments, PSF forward bending motion is increased compared to VBT. These results provide evidence-based information, hopefully helping patients to navigate claims that they find from a Google search, but also help them navigate this really sometimes difficult treatment decision. And in short, a PSF will cost you about 20 degrees of forward bending, but overall side bending motion, it may not be different between tether and fusion. As Dr. Wise mentioned, I also would really like to extend a special thank you to all the scoliosis patients who participate in our research. You are the ones who are helping improve care for scoliosis patients worldwide. And we, as researchers, we just couldn't do it without your participation and your support. So thank you. That's all I have.
Thank you, Michelle. That was fantastic. We might have, let's see. We actually have a, looks like we've caught up a little bit. We have a minute. If we have any questions from any of our participants, you can go ahead and ask it now. Otherwise, we'll move on to a couple of the main events we have of the night. Right. Well, without further ado, I'm going to introduce one of our superstars tonight. It is Sage Spear. She's a patient with scoliosis who's going to tell her bracing story.
Hi, everyone.
Thank you so much for joining us.
Okay, so like he said, I am Sage Spear, and I'll be sharing my story about my scoliosis and bracing. Next slide, please. So I grew up with 3 brothers, and my brother standing directly next to me here, Forrest, had scoliosis for as long as I can remember. He had a partial spinal fusion when I was very young, and more recently he had almost a complete spinal fusion. So you can see his x-rays here. And I did have a very good understanding of scoliosis growing up and how it could affect somebody. Up until the point where I was diagnosed. So next slide. So I was diagnosed at the age of 11 by my primary doctor. And when she noticed the curve in my spine, she had told my mom that we were just unlucky because she had known about my brother's previous diagnosis. And I then had to wear my back brace. I had a Boston brace that I had to wear 23 hours a day up until the age of 13. I really struggled with it. I felt like the only 11-year-old in the world that had to wear a back brace. I didn't understand why this was happening to me. I felt extremely uncomfortable at school. Next slide. So you can see here, at the age of 11, before starting any bracing, my curve was at about 20 degrees. And then when I was 16, 3 years after I stopped bracing, my curve was at about 47 degrees. I did not wear my brace as much as I should have. I was very defiant. I absolutely hated it because I felt so uncomfortable at school. And I had a lot of issues with my body image growing up due to bracing and how I looked even after. Looking back, though, as an adult, that time in my life that felt so awful when I was going through it was so minor. It was just a stepping stone to get me to where I am today. I learned that I am my own worst critic, and nobody else can see those terrible things that I can see, and they really aren't so terrible after all. So I do now compete in pageants. So next slide. And I currently hold the title for United States of America's Miss Midwest, and I'll be competing at United States of America's Miss this July. So this is something that I've really been able to turn into something positive in my life. I've been able to do a lot of philanthropy work and been a positive role model for other women and girls. Without that negative part of my life of the scoliosis, I wouldn't have been able to turn it into this great thing where I can inspire other people and share my story so that others don't have to feel as terrible as I felt and as isolated as I felt when I was going through that. So next slide. My platform called Every STEM Has a Story is something I started to help others feel more empowered in their diagnosis. And I designed a crew neck sweatshirt, which I sell as a means to raise money for scoliosis research. More recently, I did publish a coloring book for scoliosis patients, which is available on Amazon. And I also am an ambassador for Setting Scoliosis Straight, which has been really awesome. And reading the stories on the Setting Scoliosis Straight website has been something that actually helped me to realize how I wasn't alone. So if there's anything that you take away from what I have to say today, it's that the least interesting thing about you is the way that you look, and it's the impact that you leave on others that matters the most.
Well, Sage, that was terrific and inspiring, and love your slides and what
you.
you're doing to help others. And congratulations on your Midwest title. That's great.
Thank you.
In my experience, and I've been practicing almost 30 years, in my experience, bracing can be very challenging for many of our young patients who are going through a time of change in their bodies and an emotional time often. What are some of the practical strategies and maybe tips that you can give to audience members? And there'll be a lot of people viewing this webinar after tonight on our website. What are some of the strategies you suggest to help empower young people, adolescents who are going through scoliosis bracing to make it more palatable?
So at the core, it was helpful to me to know that wearing my brace was what was best for me. And as awful as it felt, nothing anybody says to you will last forever. Nothing, like, the way that someone makes you feel won't last forever, but the effects of wearing your brace will last forever. So if you just don't wear your brace ever because someone makes you feel bad, that affects you long term. But if someone makes you feel bad, that alone won't affect you in the long term. So I think that's really helpful. And I think it's also helpful to look towards the future and know that you won't have to wear the brace forever. The brace won't be with you forever. It's temporary, just like anything. And that's why I said, looking back, for me, it's like a stepping stone to get me to where I am today. That feels like such a minor point in my life. But when I was in it, it felt terrible.
That's a great answer. When I first started practicing, we would tell our patients, you should wear your brace 20 hours a day, 23 hours a day. And I think that's a little bit impractical, or a lot impractical for most patients. And I think that we now usually suggest that our patients wear the brace for 16 to 18 hours per day. And that's based on research, a prospective study on bracing called the BRACED study, which was NIH funded. And that showed us that if patients do wear their brace, more than 14 to 16 hours per day, there's a very high likelihood of success in preventing the need for surgery. So we try to empower our patients with that information. And then the 16 hours that we recommend usually doesn't have to be in a row, doesn't have to be perfect every day. And so we try to empower our patients to, on average, wear it 16 hours per day. So some days it may be a rainy day and you're curled up with a book. Maybe you're going to wear it 20 or 22 hours that day. And that gives you, if you've worn it 22 hours, another 6 hours to spend over the course of that week. And we'd just like to see consistency overall, but not perfection. And I think that's one of the things that we've done to empower patients. So I really thank you for sharing your story. And now we're going to go on to Jules Guarrera, who's had her own story of spinal fusion. And Jules, we look forward to hearing about your story.
Hi, I'm just going to share my screen here. All right. So as I was introduced, my name is Jules Guarrera, and just a few other things about me. I'm a rising second year at Northeastern University, where I'm studying computer science and cognitive psychology, and I was born and raised in New York City. So a bit about my scoliosis surgery. I was diagnosed at the age of 2 with scoliosis. And it wasn't really a problem. It was just something that was watched as I would go to my yearly checkups. And then at around 10 years old, my curve had progressed to the point where a brace was recommended. So this is my curve on the left over here. And then this is what my curve looked like after I was in my nighttime brace. So I wore that nighttime brace almost every night for 2 years. And then 2 years after my nighttime brace, my curvature had progressed enough where I was told that I should be put into a day brace. So this is me graduating from my day brace. But I was wearing it upwards of 23 hours a day for almost the entirety of my middle school experience. And as Sage said, it's definitely mentally very taxing. Being a teenage girl who already has a lot to figure out, and then on top of it, having to be in plaster for almost the whole day. So this is what my curve looked like before I was put into my day brace. And at the end of 8th grade, I was told that because I'd stopped growing, my curves probably wouldn't progress anymore. So I graduated from my back brace, which I was really excited about. But in order to keep my back feeling good and just prevent some pain, I started Schroth therapy, which helped, and I definitely felt better. I think I grew a little bit too. And I was just so thrilled to be going into high school braceless. And this is actually me doing the EOS study that Dr. George was talking about before to prevent radiation. During COVID, I faced a lot of back pain, and I noticed that my body was visibly changing. As you can see on the left here, it was really visible in my hips, and I became super self-conscious about it. But I just blamed it on sitting in my chair for almost all day because of online school, and then also weight fluctuation. I thought I could just see my curves more. But when I finally went to the doctor after the pandemic had kind of settled down a little bit, I was told that my 2 curves that were previously 30 degrees and 40 degrees had progressed to 40 degrees and 50 degrees respectively. And you can see that on the right over here. It was pretty severe. So at that point, I kind of had an option to either just live with it and have it get worse. And I was told that it would just continue to progress probably, or I could have surgery. So going into my senior year actually of high school, I had my spinal fusion surgery. So I had 2 rods and 26 screws put in my back, which spanned 17 inches down the entirety of my back. As you can see, this is, I think, the first day after my surgery. So from my T1 to my L3 vertebrae, so essentially my whole back. On top of it, I also tested positive for COVID on the last day of my hospital stay. So I was just having really bad headaches and neck pain. This is my before and my after with my 2 rods and 26 screws. But as for my recovery, I stood up the day after I had my surgery, and I was walking later that week, I think just a few days after. I was notoriously the floor's fainter, and I was getting super lightheaded, but after just a few days, I was back on my feet and I was feeling great. After 3 months, I was really progressing, and I went back to school every day. I was doing physical therapy, and I was walking a lot. Plus, I found myself capable of almost doing everything. And not that many teenage girls can say that they're the Terminator, which I can say because I'm part titanium now. And I just want to thank everyone. This is my amazing surgeon, Roger Widman, at the Hospital for Special Surgery in New York. And if you guys have any questions, please feel free to email me at that email right there. And then parents, if you want to get in contact with my mom about what the role of being a parent is through this whole experience, please feel free to reach out to my mom, who put her email over here. All right, I'll stop my share, see if we have any time for questions.
Yeah, thank you so much. That's just an incredible story, and you know, one that certainly has some twists and turns. I mean, your journey started really early on, and it just really continued. Can you talk just a little bit about, you know, that your mindset of not having a brace and feeling that maybe scoliosis was behind you, and then all of a sudden that journey into realizing that it wasn't gone, and sort of what brought you through that?
So it was definitely a pretty quick decision for me, because I think when I found out, it was like the very end of spring, and there was only 1 surgery day left for that summer. And I wanted to have maximal time before I was going back to school full time. So it was kind of a decision that I made within about a week. And Obviously, my friends and my family were really supporting me through it, but that's not to say that it didn't come without challenges. And as a teenage girl, especially, I feel like there's a lot of pressure on looking a certain way and feeling a certain way. And I just kind of realized that without taking the next step, I would just continue to feel worse about it. And although my future was kind of unprecedented and I wasn't exactly sure what scoliosis surgery was going to look like, foundations like Setting Scoliosis Straight and talking to people who had the surgery before me really put me in a place where I was confident in myself going into the surgery.
Thank you. You guys are certainly heroes and being advocates for a cause that really impacts a great deal of people. So really thank you for that. And really thank you for all that you do for, the education of scoliosis, but all the people you inspire. So thanks a lot. I want to go through a few announcements here. Thank you again, everybody, for joining this webinar. Want to give you a heads up what's coming up in the in Scoliosis Awareness Month, which is in June. We have a patient-to-patient webinar on June 27th at 5 p.m. Pacific time. That's going to be a true kickoff and celebrate Scoliosis Awareness Month. Next. In addition, as many of you know, all this work that is being done here at Setting Scoliosis Straight and the Harm Study Group is done through the generosity of our industry sponsors and just our contributors and philanthropists out there that really, from the bottom of their heart, care about our cause and donate to it. So please, if you're inspired to do so, help us out. I think the research is definitely groundbreaking, and certainly your contributions make a huge difference. Next slide. We do want special thanks to our research sponsors on the screen here to the right. Next. Some great news here. We have the Harm Study Group and Setting Scoliosis Straight actually puts out a idiopathic scoliosis handbook. And we're happy to announce the release of our 4th edition. In it, we have new bracing information, some more information on vertebral body tethering, bandages and scars, future technologies, and a ton more that we're excited to share with you. So please get a copy for yourself. And there's a QR code here to give you some more information on how to get a digital version. Also, again, thank you for participating tonight, but don't let it stop here. The Setting Scoliosis Straight Foundation has a YouTube channel. You can scan the QR code here to get access to that. On there, you'll find lots of educational videos, helpful tips, some research publications, more patient stories and interviews, a lot of frequently asked question videos, and also some past recorded webinars that you guys might find quite useful. Next. In addition, after tonight's webinar, there is a survey that you'll be able to take, and we ask that for all the attendees that you do so to help us keep coming up with content that is beneficial and helpful to you, and also improve on how we do it. So thanks so much for your participation. All right. I think that concludes our webinar for tonight. I really want to thank all of our panelists for joining us tonight and the hard work that they put into giving you this great content. I also would like to thank all the participants for joining. Again, this is for you, so please, your input is imperative. So go ahead and take that survey. But that's it for me. So thank you guys very much for joining.